much for the opportunity to present here. Some of the work that will be discussed here was presented in the last meeting during CNS in Boston. And so it will be a repetition for some of you, and I apologize for that. But there are new faces in this audience, and I would go over some of the work that we did with the paper in JNS. And I had some time to think about it. One of the comments during the last presentation was, are you not enthusiastic about using diffusion tensor imaging for Chiari? And I had time to think about it, and I definitely am enthusiastic about it, and I have certain concrete type of ideas as to how we can measure it and how it could be done in the setting of a study. So these are my sources for funding, and I'm grateful for the funding support that we're receiving in the lab. For the purpose of this talk, there is no relevant funding so far, and hoping to have more funding for the studies. And I'll start off by saying that the paper that we published in Journal of Neurosurgery was done while I was a fellow in Toronto working with Dr. Hodai in her lab. And the title was Diffusion Tensor Imaging Assessment of,
if you could lean a little bit closer to the mic,
of microstructural brainstem integrity in Chiari Malformation type 1. And several of the contributors for the project are on the paper already. We're going to be talking about three things today. And the first thing is whether it is feasible to obtain microstructural imaging in patients with Chiari-1 malformation. And I'll share with you the experience that we had from Dr. Hodai's lab, the metric that we used to measure microstructure and microstructural integrity, the case control comparison, pre and post comparison after surgery, some of the results showing how the FA was significantly elevated, implying that the microstructure of the brainstem was significantly different in Chiari-1 patients, and a little bit of the initial data that we saw that patients with Syringomyelia may be a little bit different, and then discuss with you some of the unanswered questions or the path for future, where we need to look at the reliability of these metrics, predictive value of these matrices to understand if they can be clinically useful. And then future directions, specifically thinking about the study design and what needs to go into a good study that could be clinically useful. And some neuroimaging considerations. I had time to think about what could be a good neuroimaging method to look at brainstem microstructural integrity. So the first topic about whether it is feasible to do these kind of imaging in patients with Chiari-1, the motivation came from the fact that patients with Chiari-1 present with headaches and signs and symptoms of brainstem dysfunction. These included dysphagia, sensory disturbance, motor weaknesses, myelopathy. And the diagnosis with tonsillar herniation really doesn't capture the brainstem dysfunction aspect of it. And all of you have experienced that in your own clinics and clinical practices. There are lots of individuals who have tonsillar herniation and are asymptomatic and really don't know whether the degree of tonsillar herniation or the shape of the tonsils is what really affects the brainstem and changes the brainstem microstructure. There are other metrics that have been looked into but had poor clinical correlation. So we wanted to explore whether it's feasible to do an imaging-based assessment of brainstem compression. And the metric that we used is fractional anisotropy, FA as an abbreviation. And FA is a metric that's calculated each voxel in the brain where you look at multiple diffusion directions and assess the diffusion of water molecules along three major directions. And at the end, you have a fork in the road at this stage, whether you could go towards tracking white matter fibers in the brain, or you start doing quantitative assessment of microstructure with FA. And the formula used to calculate is as follows. Overall, though, FA is it's a scalar metric. It varies between 0 and 1. So if you put a voxel in the CSF in the ventricle, the FA will be 0. And if you go towards gray matter, predominantly gray matter voxel, then it's typically less than 0.2. And for voxels with white matter and high density of white matter pathways, it's more than 0.2, more towards 0.4 or so. And the in vivo work demonstrated that mainly it's determined by the exolemma and the myelination in white matter tracts in brain. It is reasonable to assume that FA, if it's measuring diffusion of water molecules, then if you have external compression and white matter pathways come closer together, then the anisotropy of diffusion should increase, meaning thereby that the diffusion of water molecules should be more restricted after you have external compression. And so FA should go up after an external compression. This condition could hold on if the damage in CNS is not permanent. If there is irreversible damage and there is damage to myelination and the external membranes, then FA could decrease as well, where pathology can really increase the diffusion of water molecules in all different directions, thereby decreasing the anisotropy. So FA could become normal, even though there is permanent damage inside the tissue. Once reorganization sets in, the FA can increase further again, where you could have diffusion of water molecule preferentially in certain directions, where the remyelinated tracts can again come into picture. And so what I'm saying here is that doing FA measurement at different time points during the insult can really matter. Early on, it could increase. If there is irreversible damage, then it could decrease, and finally with reorganization, FA can increase again. So the hypothesis that we had, given the context that you just heard, was if there is brainstem compression just proximal to the tonsillar herniation, then it should show up as increased FA. So just proximal to the tonsillar herniation, the FA should be elevated in patients with Chiari malformation. And we tested this hypothesis in 8 patients with Chiari 1 and 16 healthy controls. The controls were age and gender matched, and we did a posterior fossa decompression with duroplasty in all of these patients. All of these patients improved afterwards, and I'll show you the data about improvement as well. We did a preoperative imaging and a postoperative imaging somewhere between 3 to 6 months. The images were obtained with a 3T scanner. There was a structural T1 and a DTI scan. DTI scan had 60 directions, and the voxel size was anisotropic. It's 1 millimeter by 1 by 3 millimeter. This is something that we'll discuss towards the end. And the clinical information was assessed in a blinded fashion, and we looked at 2 metrics, the Chiari Severity Index, where a higher score between 1 and 3 means more severe Chiari symptoms, and a Chiari outcome score between 4 to 16, where a higher score means a better outcome afterwards. The images were processed using software called 3D Slicer. We co-registered the anatomical T1 and the DTI images and did the artifact corrections for all of these images, which is a standard post-processing step. We also assessed some structural parameters, tentorial angle, posterior fossa volume, ACPC length, and also did microstructural assessment in 2 axial slices just above the foramen magnum. And this was done in anterior brainstem compartment and posterior brainstem compartment. And so this picture shows you the site of the compression and the anterior brainstem ROI and the posterior brainstem ROI. And the reason why we chose 2 separate brainstem compartments was because posterior brainstem compartment is closer to the 4th ventricle and is likely to be more affected by changes in CSF dynamics or patients with Syringomyelia. The second important reason was that the functional organization of brainstem, anterior and posterior, is different, where the large white matter tracts are mainly in the anterior compartment, and the inferior olivary nucleus is the only gray matter nucleus anteriorly, while posteriorly you have several nuclei, including the nuclei for the vagus nerve and the nucleus tractus solitarius, although there are some white matter tracts as well posteriorly, including the inferior cerebellar peduncle. And so the heterogeneity in the posterior brainstem compartment was more, while the anterior brainstem compartment was less. So we divided it into two different parts. These were the 8 patients, their clinical presentation, and their outcomes. So the age varied in people in their 30s all the way to 60s, and the severity in most people were 1 or 2. But we had one patient with Chiari severity index of 3 as well. All of these patients had signs of brainstem dysfunction. They had myelopathy, absent gag reflex in one form or the other. And the other interesting thing is that patients 2, 4, and 6, which are highlighted with the stars here, were 3 patients who had Syringomyelia. So patient 2, patient 4, and patient 6. After surgery, we had follow-ups for 3 to 15 months, and one patient even had a 2-year follow-up. And all of the patients improved in terms of their symptoms, and most of the improvement index was between 13 and 15. We had one patient who did not significantly improve, had a Chiari severity index of Chiari score of outcome score of 9. When we look at the structural metric, the tonsillar herniation was the only significant association that differentiated Chiari patients from controls. Other metrics, including ACPC length, total brain volume, posterior fossa volume, were not statistically significantly different between the two groups. One important finding that we found right away is that we could only obtain useful imaging in 8 out of 20 patients to do these kind of structural metric analysis. And the challenges we identified were either the slices wouldn't go all the way down to the brainstem, to the foramen magnum, or there was big artifact related to motion, or there was artifact related to the sphenoid sinus, which sits very closely to the clivus, just anterior to the clivus. The summary of the results is as following, and I'll show you some figures afterwards. So FA was significantly higher in Chiari patients as compared to controls. So as we discussed before, when brainstem external compression, more anisotropy could lead to increased FA. So in Chiari patients, the FA was 0.52, in controls it's 0.42. And since it's a scalar metric, it's a significant increase of 0.1 is a significant increase. The FA normalized after the posterior fossa decompression. It came back down, except for in Chiari patients with Syringomyelia, FA was persistently elevated in the posterior brainstem compartment. So patients with Syrings, FA increased by 13.4%, while in patients without Syrings, it decreased by about 1/3, 31%. So patients with Syringomyelia, the brainstem compartment posteriorly, had persistently elevated FA, and this result was statistically significantly different. There was a similar trend in patients with Syrings, even in the anterior brainstem compartment, implying that there may be microstructural changes in patients with Syrings also in the anterior brainstem compartment.
Did the Syrinx patients get worse, or were they still 13% different from normal? The FA.
In FA, increased.
It increased in the same patients?
Same patients.
So it became worse?
Worse afterwards. And so is it truly implying worse, or is it implying reorganization? I don't know. If it is reorganization leading to increased FA versus continued pressure, I don't know.
But it makes some sense that the packing would be from inside rather than outside as well. So in the Syrinx, you can increase the FA because the CSF in the spinal cord, right?
No, but they're looking at the Brainstem.
I know, but it's
The fluid's making its way up.
that's how it gets out. So you have a Syrinx there, and so the white matter tracks that you're looking at are going up and down.
Yeah.
So that they're packed maybe, and they may be packed lower down, but it still has
series published in 2004 of Syringomyelia. And Chiari, all the patients with Chiari and Syringomyelia improved after surgery, except the patients with kyphotic clivoaxial ankles. So I wonder if you have 3 patients with Syringomyelia that did not improve but got worse, may be subject to increased stresses ventrally. Professor Brieg in the 70s showed that a ventral compression on the brainstem or spinal cord causes increased stresses posterior on the posterior aspect of the cord.
Yeah.
And so it'd be interesting to see the pictures of those patients.
Yeah. So these are excellent comments, and I always wondered whether the taking away of the posterior tension band was somehow resulting in more mechanical compression. Point well taken.
I'm sorry, it wasn't clear to me that we know that the FA didn't get better. Was it clinically, was the patient better?
Clinically, patients were better. Yeah. If you look at these people, 2, 4, and 6, these were the Syringomyelia patients. So outcome score of 15, 10, not that much. They have persistent hemibody numbness. And 6 had persistent neck pain and left arm and leg numbness. So there were some persistent symptoms, although radiographically these patients, the Chiari, the syrinx decreased in size, did not require any additional surgeries for the syrinx itself. So.
Did you do any control groups on patients who just had suboccipital decompressions but didn't have Chiari, just to see if it was effective the surgery?
We didn't. Yeah, this was the initial feasibility study.
So, what do you think is physically, on a cellular level, what do you think is going on to elevate the FA?
At a cellular level, the conventional wisdom is that the extracellular matrix is where most of the diffusion of water molecules comes into picture that determines your FA. So if an external compression that's not degenerating the tracts but is restricting the extracellular space will lead to increased FA, increased anisotropy.
So it's decrease in the extracellular space. It's not a change in the axoplasmic flow or some intracellular process.
Most likely.
Are you going to show us some images?
Yes, sir. So these are the pictures of the results. So these are not images. Next time I'll come prepared with the images too.
Well, I just wondered if the neurosurgeon could tell you have to run it through a computer.
So these are the FA comparisons between cases and controls. So these are healthy controls compared with patients with Chiari 1 malformation. And the FA value in the anterior brainstem compartment is shown with these darker circles. So as you can see, patient number 1, the FA is higher than both its controls. Patient number 2, it's kind of somewhere in the middle, but most of the patients, the FA values are higher than their respective controls. This patient number 2 had syrinx, as we said before, and patient number 8 again had FA higher but very close to the controls as well. When we look at the overall summary statistic with comparison, this is statistically significantly different, that the anterior brainstem FA was higher in CM1 patients than controls. In posterior brainstem compartment though, the picture is more unclear. So the FA values are overlapping in this patient, for example. It's somewhere in the middle between in this patient, higher in this one. So it's all over the place in the posterior brainstem compartment where the reliability of having a elevated FA goes down in patients versus controls. And so this result is not statistically significantly different. When we looked at pre versus post, so this is a diagram that shows FA value in post-op state is in red, while pre-op state is blue. So if you see more red, that means the FA increased after surgery. If you see more blue, that means FA decreased after surgery. So when we look at the patients with Syringomyelia, I listed them right in the beginning. In one patient, the FA increased after surgery. It decreased slightly in the other one. In the third one, it again increased. While in the patient who didn't have Syringomyelia, the FA consistently decreased. When we look at posterior brainstem compartment, the picture is less clear. There is one patient where the FA increased in Syringomyelia, in other two relatively unchanged. Probably this is the patient that influenced most of the change in FA afterwards, while it decreased in most of the patients who did not have Syringomyelia. So to summarize these main findings, first of all, it's difficult to obtain brainstem imaging to assess microstructural changes in patients with Chiari malformation. The second conclusion was that the FA is significantly different in Chiari patients as compared to controls. And there may be some differences in patients who have Syringomyelia. The elevated FA resolves after surgery. And the other thing that I should bring in understanding how FA can go up and down is that a single assessment may not be giving us the entire picture as to what may be happening 1 month after surgery, 3 months after surgery, or 6 months after surgery. So the limitations of this study are, it was an initial feasibility study, so the small sample size is a major limitation. The anisotropic voxel in DTI can be a problem as well. Follow-up imaging was a single time point, and it was a variable time point between 3 to 6 months. And the ROIs that we placed in the anterior brainstem and posterior brainstem are large. They are spanning across several tracks, and so we don't have track-specific information in this study. And then as far as the imaging analysis goes, if I look back at this today and criticize this, our own work, then I would say that DTI may not be the best metric to assess microstructural integrity in the brainstem. The reason being that DTI is influenced by a lot of different factors, including your blood pressure, the time of the day when the imaging is obtained, and the position of the head. So a lot of different things go into determining the signal-to-noise ratio that we have in DTI studies. So where this left us, and last time it may have come across as sort of not that enthusiastic conclusion of the talk, is there are some unanswered questions here. And the first unanswered question for a clinician is it a reliable metric where we could use this metric of microstructural integrity to understand if there is brainstem compression in Chiari 1 patients and whether decompressive surgery relieves that. So the reliability of this thing is unknown. As the point was raised, whether FA changes just because of the surgery itself without even decompression. These are the questions that need to be answered. And the second one will be, is it predictive? And so the next step will be determining the predictive value of this in looking at the severity of compression and also the adequacy of decompression in light of FA metric. And one more thing that comes to mind is that most of these patients are showing up for pain. And we, for the sake of studying this, focused on microstructural integrity of the brainstem. And so the pain aspect of it likely will need additional studies, including functional MRI, to understand how the networks in the brain changed really before and after the decompression. So if you think about the study design for this, it will likely be a large cohort study. It will be a multi-center study to detect a 0.1 difference in FA. With the standard deviations that we had, we will at least need 17 patients, case versus control comparison, in a 1:1 case control design. The controls should include healthy controls, but also maybe patients who have asymptomatic tonsillar herniation. And there are experienced people in this group who see these patients coming through. They had brain imaging, found to have tonsillar herniation, are asymptomatic. It'll be very important to study whether asymptomatic tonsillar herniation has the same effects on the brainstem and the microstructural integrity in the brainstem. And the reliability of these metrics need to be tested in a test-retest analysis, even at baseline, to see if it is changing too much even before we embark upon using this in a clinical setting. And then longitudinal imaging assessments need to be done to really understand how it's reorganizing and how the changes are happening in the brainstem. And finally, the predictive value to assess its correlation with clinical symptoms. For the imaging analysis, there are several things that need to be done if a study were to be undertaken for this. And the first one would be a clinical coordinator will have to be present when the imaging is being done for these people to assess the following: whether there was significant head motion, whether the field of view incorporates all the way down to the brainstem, and whether there are significant artifacts that they can determine right away just by looking at images. It was challenging to, it was not challenging, but I was not happy to see only 8 patient data being used at the end while we had 20 patients imaged pre and post for this kind of analysis. And the imaging analysis, we could use more sophisticated algorithms today, including GQI, and use a data-driven approach where we completely sort of back off and say, depending on the data that we have, are there truly differences between anterior and posterior brainstem compartments? How do we segment this part of the brain to really understand these microstructural changes? And then also include assessment of function. This is something that can be easily done in a protocol by adding 7 or 8 minutes of scan time to have functional MRI. Just a little bit about the GQI. Someone earlier, when they were looking at the retest reliability, talked about the non-parametric approaches for this kind of analysis. So GQI is a non-parametric way of looking at diffusion of water molecule in the brain, and it does not assume any type of preferential direction. It really looks at the diffusion of water molecules in multiple different directions, and it's a better metric of looking at microstructural integrity. The other important thing that GQI implementations can do is they can remove CSF contamination from each voxel. So in patients with Syringomyelia, it will be very important if we could remove CSF contamination by understanding whether the changes are related to swelling or just the syrinx being there, or truly reflect the microstructural changes in the neuronal compartment. So I'll give you an example here. So in my lab, we look at patients with Parkinson's disease and essential tremor who have a lot of neurodegeneration. And if you look at the FA type of metric in these patients, voxel-wise, in the brains, in the basal ganglia, the FA metric actually is very low. The signal-to-noise ratio of that FA metric is very low. When you use the GQI type of algorithms, you can boost your signal-to-noise and truly understand the microstructural integrity better. So this will be a way that could be used in Chiari patients as well. And what I mean with the data-driven approach is, this is a figure in a patient. We segmented their thalamus just based on the diffusion of water molecules. And it looks to us that before doing the thalamotomy, there were 7 parcels within the thalamus, and we have denoted it with different colors. And this picture captures mainly the ventral thalamus. And after creating a thalamotomy of the size of 4 to 6 millimeters, the data-driven technique was sensitive enough to pick up more parcels. So now you had 8 parcels within the thalamus just based on that segmentation. Overall, what I'm trying to imply here is, instead of identifying ROIs beforehand, we could use the diffusion of water molecules to segment brainstem and really understand what compartments within the brainstem are the ones that are getting the most compression, whether it being more posteriorly, in the middle, or more anteriorly. So a study for this kind of a analysis could look something like this, where you have a group of symptomatic Chiari patients who have preoperative imaging, and a small subset of these would have a retest at baseline, and then they would have 1 month post and a 6-month post to look at these microstructural changes. Then another group of people with incidental tonsillar herniation with a baseline assessment and a 6 to 12 month follow-up post as well. And finally, healthy controls to understand baseline, but also a small proportion of those would also have a retest reliability metric as well. So overall, we talked about 3 things today. One was that it's feasible to obtain microstructural imaging It takes a lot of effort, and we will have to be more careful about the acquisition of imaging and be very vigilant when the images are being acquired. And that FA is significantly higher in brainstem in patients with Chiari malformation than controls, and it tends to normalize after surgery. Patients with Syringomyelia may be a little bit different. Then the second point that we discussed is that this study is just a feasibility study, and the reliability of this and predictive value is unknown. And finally, we need future investigations to study this in a test-retest kind of a design, case control design, pre-post design. And the neuroimaging analysis will need to be more data-driven, where we segment the brainstem to understand which compartments within brainstem have the most compression and which decompress the most. Thank you.